Jeff, in the pain center that we ran together years ago, we always paid a lot of attention to the difference between the nociceptive aspect of pain and the suffering aspect of pain. And we tried to drive that concept home to the patients.
Yeah.
Could you provide us with a definitional difference between those two pieces?
It's an important distinction. Nociception really is the input to the brain, the sensory input from the periphery. And it's raw and has no particular emotional valence one way or the other. Suffering actually is what the brain does with that nociceptive input.
Yeah.
We think about pain, importantly, I think, as an output of the brain as opposed to an input. So the suffering side is the information that our brain attaches to nociceptive input.
A little bit as though it's sort of tagging the nociceptive inputs as being very threatening or not so threatening.
Right. We add meaning based on our
Okay.
history, our experience, our emotional state at the time, the way we think about it, the beliefs we have and assumptions we have. And that's what contributes to how a patient responds to that nociceptive input.
Okay. And so why is it important to make the distinction or to teach the distinction to the patients?
Well, I think because if they understand that distinction, they can also understand that, as so many patients we see feel out of control with their pain. And while they may not be able to establish a sense of control over the nociceptive input, it's not really in their control nearly as much as the emotional response, as the cognitive processing is of that nociception. So we talk about how this is something they really can control, even if they can't affect that input from the periphery.
So that would be a part of teaching them self-efficacy in some way?
Exactly right. If they make that distinction and can understand that if they can work to change their thinking about the pain, they can begin to work on it, understanding unreasonable assumptions they might be making, replace them with healthier ones. They can work to address depression, for example, a depressive response,
Right.
by engaging in more pleasurable activities, by working with a psychologist to address those depressive responses. Then, in fact, what they're doing is learning to take control of that pain that has so dominated their lives. Dennis Turk once said, pain's not in our body, it's not in our brain, it's in our lives. And I think that that's an important recognition that this is all encompassing for patients.
Right. So as a physician, it would seem important that I might be able to begin to make that distinction for the patients and to the patients so that they can embrace the idea that cognitive behavioral therapy will be helpful to them. And of course, we'll cover the cognitive behavioral therapy itself later. But how, as a physician, might I begin to help them on that journey if they haven't understood that before?
Well, we have found that often if you begin to elicit adjectives that the patient, him or herself, uses to describe their pain experience, you can distinguish between adjectives that have sensory connotations versus adjectives that have emotional ones. So for example, if they say their pain is throbbing or stabbing or aching, those are sensory descriptors. On the other hand, if they use adjectives like, it's overwhelming, I can't stand this anymore, it's unbearable, punishing, those are emotional responses, and if we can elicit those descriptors, then we can also point out that the latter really are responses to what they perceive as that pain input. And we can reconstruct it for them as saying, actually that's a pain output, and that suffering quality, the distress that you experience, is something that you can learn to address. And that's what the role then of a pain cognitive behavioral therapy specialist really is.
So as the physician, of course, I'm not going to be doing the job that the psychologist is able to do, but I could elicit some information or some thoughts from the patient, pay attention to the adjectival description the patient is using,
Yes.
and then come back to the patient and maybe make the distinction for them that some of these adjectives you're using really sound like you're suffering a lot. And
Yes.
perhaps come back with the question, have you considered that there are two parts to your pain?
And in fact, I think acknowledging and validating that suffering helps to avoid that common trap where patients will quickly be alerted to the idea that you may be arguing that the pain is all in their head. And in fact, what you're doing is validating their experience and beginning to dissect the various contributions to their pain experience in a validating as opposed to dismissive way.
Great, that's so helpful. So then, as a physician, then I might conclude, how would you move from the description of nociception versus suffering for the patients to the idea that a cognitive behavioral therapy referral might be helpful to them?
Well, I think by establishing that distinction and helping them through through eliciting their own experience, recognize the truth of this for them, then I think you can, by extension, say, the next step in this process is learning to take control of what you can. Sort of the St. Francis idea of identify what you can versus cannot control and attend to what you can. This is now laying the foundation, I think, for a successful referral to a psychologist who practices CBT.
And do you find it useful to say something like, so it seems as though you have two components to this pain experience. We address the nociceptive component in one way, injections, drugs, what have you, but none of those drugs will address the suffering that requires an understanding of what your own brain is going through.
Well,
would that be helpful? Or?
I think it is. It's helpful because then it helps our patients begin to identify the complexity of pain. It is not just that this hurts and can you take that hurt away, but
Right.
it begins to represent all of the various aspects of unpacking kind of the various aspects of pain. And helping the patients develop a sense of insight into all the elements, not just kind of in a reductionistic way that they think of pain, but beginning to help them have a more sophisticated and comprehensive view of pain, as we hope physicians and practitioners do.
Great. Thank you, Jeff. That is so helpful. Do you think you could summarize in just a few words what we covered today?
Sure. So what we've learned today is that it's important to distinguish for patients between nociception on the one hand and suffering on the other, and that it's important to help our patients understand this important distinction, often most usefully by asking them to use adjectives to describe their pain experience and identify those adjectives that relate more to sensory qualities of pain and contrast them with emotional and cognitive qualities of pain. And that distinction then helps us to validate their experience, to begin to unpack their experience, to understand its complexity, and it lays the foundation for a successful transition to and referral to a cognitive behavioral psychotherapist who can take it from there and help them establish a greater sense of control over that component of their pain experience that may eventually be in their control and help to learn to manage their pain much more successfully than they had heretofore.